Hello friends, welcome to Shri Netralaya. Expulsive choroidal hemorrhage or expulsive vitreous hemorrhage is uncommon but sight-threatening dreaded complication in open sky penetrating keratoplasty surgeries. Specifically, if you are operating the case with cataract extraction. It is caused by sudden catastrophic bleeding in vitreous cavity leading to rapid increase in intraocular pressure with expulsion of intraocular contents. The incidence may range from 0.5 to 3% and may go higher with open sky techniques. It may be even higher in cases who are high risk like previous vitreoretinal surgery cases, active inflammation, neovascularization, scleral thinning. Let's discuss the pathophysiology. How this happens. Sudden decompression. The core mechanism is believed to be rapid decompression of eye during open sky procedure, which can disrupt the fragile blood vessels. Choroidal effusion or hemorrhage. This can decompress or can trigger a choroidal effusion, that is a fluid accumulation and hypertensive effect. The bleeding into the vitreous cavity creates a hypertensive effect that pushes the graft outward and potentially leading to its expulsion. The pressure differential of high pressure inside choroidal vessels versus near zero IOP in open eye that can cause vessel rupture and thereby expulsion of vitreous contents. The key risk factors are ocular comorbidity, prior RD surgeries, vitreoretinal pathology, neovascularization, high IOP, posterior segment disease, active posterior segment inflammation or proliferative vitreoretinopathy can trigger the condition. Systemic factors like advanced age, hypertension, vascular disease like atherosclerosis, use of anticoagulant or antiplatelet medications, glaucoma can increase the chances for complication. Intraoperative and anatomical factors like scleral thinning, violent or abrupt decompressing maneuvers, rapid loss of intraocular pressure, poor globe pressurization, and excessive manipulation during wound construction. These factors increase the chances for positive vitreous pressure. Preoperative status of poorly controlled glaucoma, silicone-filled eyes, or prior buckling surgery also change the globe dynamics and increase the chances for complications. The type of anesthesia used for this type of surgery is crucial. General anesthesia is preferred over peribulbar. The volume and technique used during local anesthesia also influence IOP. The larger the volume of anesthetic drug, the higher the chances of positive vitreous pressure. Evidences has indicated that IOP elevation is highest with peribulbar blocks, that is 5 to 22 mmHg can increase, followed by a retrobulbar block which can increase IOP by 4 to 6 mmHg, while subtenons block do not cause considerable increase in IOP. So selection of type of anesthesia is crucial. Preoperative considerations are very important. A thorough medical evaluation and control of systemic hypertension, review and adjustment of anticoagulant and antiplatelet agents, management of glaucoma helps in prevention of complications. Preoperative mannitol plays an important role. It decreases the intraocular pressure by extracting water from vitreous body, thereby causing shrinkage of vitreous and helps intraoperatively to keep the pressure on lower side. There is a speculum called as Ogawa 3D speculum, which is available in the market with epsilon, no financial interest though, is one of the speculum which don't cause any pressure on the globe. Alternatively, we can use lead sutures which do not cause any pressure on the globe. Controlled decompression via paracentesis also help before opening the eye fully. Despite all the precautions, complication is not an uncommon thing in open sky technique triple procedure cases. So to prevent the complication, we introduce Limbal sutures, which are sight-saving, innovative technique to prevent expulsive choroidal hemorrhage in cases of open sky triple procedures. Let's see how to use these sutures. Once the central area is marked for a proper trephination, first suture is taken at 3 and 9 o'clock position. So this will pass through the limbal area. You may have a bit of bleeding there, but that is okay. We can cauterize it. 6-0 vicryl suture is used here. The another suture will pass from 6 o'clock to 12 o'clock position, and that way it will form a plus sign crisscross pattern in the center. These sutures, if pulled, will come to the center so that it can close the globe easily and prevent the expulsive hemorrhage. Definitely we will need the graft tissue or the host tissue itself to have a good closure. Only sutures cannot close the globe. Now we can take these sutures to side and perform rest of the procedures as usual. Here I am using the 8-tooth marker to have perfect alignment and position of all sutures. These sutures prevent expulsive vitreous hemorrhage. In addition, we have benefits like rotational stability of graft. First 4 cardinal sutures will have a perfect placement so that we can have better orientation of all sutures and control of astigmatism. Because of less handling of the tissue, less endothelial cell loss is there, and you get a peaceful time to complete your surgery without worrying for expulsive hemorrhage. A proper trephination is performed and the host area is prepared to take the graft. Here I have fast forwarded and nucleus is delivered and IOL is placed in the bag. I usually use a 3-piece IOL or a rigid IOL, which give some strength to the posterior capsule and anterior hyaloid phase. This is followed by immediately placement of the graft and the sutures are pulled so that the chamber is formed immediately without applying any further sutures. So even without a single suture, your globe is closed and the anterior chamber is well formed, thereby decreasing the chances for expulsive hemorrhage. Your IOP is not 0, which is a main factor for causing choroidal and expulsive vitreous hemorrhage. Once these sutures are in place, we can comfortably use the 10-0 nylon and complete our surgery with first cardinal 4 sutures, and this forms the anterior chamber very well and the eyeball has a good pressure. This is definitely followed by intermittent remaining sutures to complete the surgery. I hope this technique will save many eyes. For me personally, case I have prevented from going to expulsive hemorrhage because of these sutures and thought of sharing it to everyone. Do subscribe to a YouTube channel Dr. Pankaj Lande for more such exciting videos.